At first, let me thank you, say to Philip and his staff, also Michelle. And we retrospectively looked into our data, potential living donors of kidneys. Our aim was to describe and to quantify the anomalies of these potential living kidney donors. And the question was, is our protocol robust and useful for surgery planning? We could look into 104 cases, as you see here, much more women in comparison to men. And the pictures as well as the radiological and the surgical reports were analyzed. Here you see our methods. The transplantation occurred in 67 cases of these 104 persons. We evaluated most of the persons with 3T. We used cyclic contrast agents with bolus timing and, of course, flash 3D sequence. We had 4 dynamic phases: native, arterial, venous, and equilibrium phase. And also we looked at the excretion to have an impression of the ureter. All scans were around 19 seconds, depending on anatomy, in one breath hold. Slice thickness between 1 and 1.5 millimeters. And we also did T2 before and T1 Dixon before and after contrast to see additional findings. Here's one picture for every phase without contrast to classify also complicated cysts. We found some complicated bleeding cysts, and also for subtraction. Here the first arterial phase, you see double renal arteries on both sides. Venous phase, equilibrium phase, and also the excretion. We did length measurements, especially this is helpful for the surgeon in these patients where we detected early branching. In this patient, early branching was detected after 5.2 millimeters. Excuse me. Here you see once more our method. We did length measurements retrospectively and also diameter measurements. Our results: in 166 persons we saw 1 renal artery, 39 double, in 2 patients 3, and in 1 patient 4 arteries. Here you can see a pitfall. This renal artery was only seen retrospectively. In the first radiological report, this artery was not included, and the surgeon found it during surgery. Regarding the veins, you see double renal veins in 10 persons and 3 renal veins in 1 person. Here you see an example, double venous system on right side. What is also to report is a late confluence of the venous system. And here you see double venous on right side. And whatever is to do, you have to look at the source images. And of course, some of our patients presented with insufficiency of ovarian or testicular vein. 3 arteries were not described primarily due to human error, and 2 of these 3 were found retrospectively. One artery was not described due to unknown cause, we don't know, but this artery was not found retrospectively. We have no intraoperative photos, artery was not transplanted, and no complications occurred. 2 early branching renal arteries resulted in 2 artery recipient anastomoses, and 1 accessory artery in MR was not found during surgery, consecutively not transplanted, but also without complication. It was also such a small artery as I showed you. 2 renal veins were seen twice in MRV, and the most common venous anomalies included multiple veins, insufficient gonadal veins on left side, retroaortic veins, and venous connections to bigger retroperitoneal veins. We detected 1 renal cell carcinoma. And in conclusion, we think that MRA and V should be the method of choice for evaluation of potential living donor of kidneys, and we recommend strongly that the pictures are re-evaluated by an experienced radiologist with the source images before transplantation, like it is common practice in our hospital for the tumor patients. And the question is, can measurement of renal perfusion with test bolus help to avoid renal scintigraphy, like Giles reported us yesterday, very inspiring results. So thank you very much.